Hello, everyone. Good morning, good afternoon, and good evening, depending on wherever you are. Welcome to our special COVID-19 session number 28. This is part of a series that we have dedicated to diagnostics in the COVID-19 pandemic. And we are always excited to have you here. My name is Anafi Mataka, and I'm excited, as usual, to be your co-host. Today, we continue with one of the key topics that we have zoned down to in the past couple of weeks, that of antigen rapid diagnostics for SARS-CoV-2, mainly because of the key potential that these tests do have in partially opening up the borders and getting us to what would call, possibly in quotes, our usual and normal lives. Why? Because they have that capability of getting us a test result within a short time. But at the same time, we do not want to forget elements of quality and everything that is related to that. So today, we have one of the manufacturers of the COVID-19 rapid diagnostics, two of which have already been listed under the WHO emergency use listing. And that is the Panbio rapid diagnostic test developed by Abbott. And to do that, we will have our colleagues from the industry and in the name of Dr. Kuku Appiah, who shall be joined with their colleagues to present to us what this rapid antigen test is really all about. This will be a 1 hour long session as usual, which shall be made up of a presentation in the beginning, after which we shall take questions and get answers. Please keep your questions and comments coming through as the session continues, and we shall take them from the chat box. Remember, we have simultaneous language interpretation from English to French, so please feel free to tune in to the channel of your choice. Let me introduce our speaker today, Dr. Kuku Appiah, who holds the position of Director, Medical and Scientific Affairs Africa for Abbott Rapid Diagnostics. Dr. Kuku is responsible for providing scientific and medical expertise, both within the organization as well as externally. She works with a network of key opinion leaders with Ministry of Health and a large complement of implementing organizations across the continent. And many of you, I'm sure you have met here already. Prior to joining Abbott, she was the medical director for Pfizer, Southern Africa, between 2011 and 2016. And she has had large and extensive management expertise, as well as management of HIV programs within the continent, having worked as a country director for the Elizabeth Glaser Pediatric AIDS Foundation in 2009 and 2011, as well as being a medical director for Aram Institute, as well as executive director for Right to Care from 2000 to 2003 to 2006. She holds an MPhD degree from the University of Zimbabwe, and she was certified as a specialist civilian physician in 1997 in South Africa, and has also served as a consultant physician within the Southern African public health system, as well as a private practitioner. So we are in safe hands. Dr. Kuku, over to you.
Thank you very much, everybody. Good afternoon, everybody. As Anafi said, my name is Dr. Kuku Appiah. I'm speaking to you from Johannesburg, South Africa, and I am the Director of Medical and Scientific Affairs for Abbott Rapid Diagnostics. I would like to present to you details and specifics around the Panbio COVID-19 antigen rapid diagnostic test that was launched recently by Abbott. So I'm going to speak up, give you a product overview, and then present the clinical results that we have that have been provided for the WHO EUL. I will speak a little bit about active infections and antigen testing, and also introduce you to 2 suggested in-country evaluation protocols that we have developed. So the Panbio COVID-19 rapid test device has been certified with WHO EUL certification. It is an in vitro diagnostic rapid test for the qualitative detection of SARS-CoV-2 antigen. It targets the nucleocapsid proteins within the SARS-CoV-2 virus. It has a sensitivity of 91.4% and a specificity of 99.8%. But as we discuss later, I will demonstrate that when the sensitivity is teased out to only involve samples that had a CT value of less than or equal to 33, the sensitivity then rose to 94.1%. The device should be stored at 2 to 30 degrees centigrade. It is WHO EUL and CE marked. The sample type available currently is a nasopharyngeal swab, and the test time is 15 to 20 minutes. The intended use of this test is as an in vitro diagnostic rapid test for the qualitative detection of SARS-CoV-2 antigen in human nasopharyngeal swab specimens from people who meet the COVID-19 clinical and or epidemiological criteria. The Panbio test is for professional use only and is intended to be used as an aid to the diagnosis of SARS-CoV-2 infection. The product may be used in any laboratory or non-laboratory environment that meets the requirements specified in the instructions for use and also guided by local regulations. The test provides preliminary results. Negative results do not exclude SARS-CoV-2 infection, and they cannot be used, negative results cannot be used as the sole basis for treatment or other management decisions. Negative results should be combined with clinical observations, patient history, and epidemiological information. The test is not intended to be used as a donor screening test for SARS-CoV-2. The kit contents. So included in the kits are 25 tests, each of them in an individual foil pouch with desiccant, and also 25 sterilized nasopharyngeal swabs for sample collection. The kit also includes 25 extraction tubes with specialized tube caps. It includes one 9 milliliter bottle of buffer, one positive control, one negative control, which is an additional uncoated swab. It comes with a paper tube rack, instructions for use, and a quick reference guide. Of note, additional items that are required to conduct the test but are not included in the test are personal protective equipment such as masks, eye protection, gloves, and gowns, as well as biohazard waste containers and disinfectants, and a timer. So the test procedure is, the contents are as I indicated, and the additional required contents equipment includes a timer and a biohazard disposal equipment. So 300 microliters of the buffer should be placed into the test tube with there is a specific mark on the tube that makes an easy reference for how much buffer should be placed in the tube. The tube should then be placed upright or vertical into the holder, and then the nasopharyngeal sample must be obtained. So the sample is obtained using the specific technique required for obtaining a nasopharyngeal swab, and also note that not everybody is mandated in the country to be able to take a nasopharyngeal swab, but using the correct technique, the swab should be placed in contact with the area for at least 20 seconds and twirled around for 4 to 5 times. The swab immediately is transferred from the nasopharyngeal area into the upright tube and swirled into the buffer solution to remove the biological material. And a feature of the tube is that it is flexible. So the tip of the swab should be screwed squeeze to remove any additional biological material. And then an additional feature is the snap off stem of the tube. So that is snapped off without having to remove the swab from the tube. The tube is then capped, and then is then closed, and then the dropper cap is removed. 5 drops of the mixture of the buffer and the biological material should be placed onto the cassette, and then the tube is capped and disposed using biohazard procedures. There is no further activity required. The test reads within 15 minutes, and the maximum read time is 20 minutes. So if there is no control line visible on the test, this test is invalid and should be repeated. If there is a control line present and the test line is not present, that test is read as negative. But if there is a control line and the test line is also present, that test is read as positive. You should note that any possible color in the test line should be read as a positive result. So there's a wide variation of what the positive test line looks like, and any trace in the test line should be read as a positive result. After reading the test and after 20 minutes, the test should be disposed using biohazard techniques. So I'm just going to show a quick video that demonstrates what I have just what I've just explained. Okay, as I explained, there is a special biohazard containment feature contained in this test, where there's a special break-off swab that stays contained in the tube, minimizing staph exposure. And also we have 2 caps that, once sealed, safely dispose the fully enclosed extraction tube. So I'm now going to present the results, clinical results as per the WHO emergency use licensing. This was achieved on the 2nd of October this year. The study that was used to provide data for the WHO EUL was conducted in Brazil during the peak of the pandemic. And this study involved clinics in 3 different cities, where all comers were the people that were presenting in these clinics or these health centers were symptomatic. So all the patients involved in this, all the subjects involved in this study were symptomatic subjects. A total of 585 subjects were involved, and the test showed a sensitivity of 91.4% as compared to the PCR gold standard and a specificity of 99.8%, leading to a total agreement of 97.8%. When the cut-off value of the CT, when the CT cut-off value of less than or equal to 33 was applied to these results, the sensitivity then rose to 94.1%. So if we had applied a cut-off value for the CT of less than or equal to 30, then the sensitivity would have risen to 98.5%. When we analyze the data and group it into two cohorts based on the day post onset of symptoms, we see that in study participants who were day 0 to day 3 post the onset of symptoms, the sensitivity was 94.9% and the specificity was 100%. We saw a drop off in the sensitivity from 94.9 to 90.1% when we looked at only subjects who were day 4 to day 7 post the onset of symptoms. This also supports the information that we provide that this test is best used within the narrow window immediately after a person is infected and demonstrates symptoms, and that at the time when antibody levels rise to a specific titer, because the antibodies will bind to the antigen, this antigen test only detects free antigen in the circulating in the system, and it will not detect antigen that is bound to antibody. So the test is best used in people closest soon after the onset of symptoms or soon after they have been infected. In this study, there were 9 study participants that were asymptomatic, but somehow were included in the study. And those asymptomatic participants were both PCR and Panbio COVID-19 antigen negative. So the performance data meets or excludes WHO requirements. The target population and the patient is for patients with acute or subacute respiratory symptoms or fever or other suspicious symptoms such as diarrhea and anosmia who are known with known contacts to a confirmed or probable COVID-19 patient or living in an area of cluster or community transmission and close contacts to those people with or without symptoms, to index cases who are confirmed COVID-19 symptoms with or without symptoms. And yes, so the current specimen type that is available and that we are shipping out is the nasopharyngeal sample. I would also like to speak about the Sympheos system for analyzing, for epidemiological monitoring. We need to know what happens when and where. So the Sympheos system is a suite of rapid testing and software tools for COVID-19 decentralized testing. So in addition to the rapid test, we have a Sympheos mobile app, and then we have desktop devices that would be utilized by program managers, such as Sympheos Collect and Sympheos Insights. So Sympheos provides real-time reporting and visualization of COVID-19 hotspots, outbreaks, and epidemiological statistics. And it enables country MOH program managers to efficiently deploy and manage scarce resources. No personal data is recorded. The test records locations and times, results, and demographics for broad epidemiological reporting. There is a possibility for asynchronous upload if the connectivity is poor at the time when the test is connected. And the target users for the Sympheos system is healthcare professionals, healthcare workers, and MOH program leaders. The Sympheos system is a decentralized COVID-19 data collection and visualization, provides decentralized COVID-19 data collection and visualization at your fingertips. So as I mentioned, it involves the mobile app which is currently available for any Android smartphone, the Sympheos Collect, which collects COVID-19 test data via a web-based portal, and then the Sympheos Insights, which provides very useful data visualization, trends, and reporting for COVID-19 test data. And this other test results can be layered into this Sympheos system, not just the Panbio COVID-19 antigen test results. So this shows an example of how the Sympheos system would be able to highlight the specific hotspots and other areas where community transmission is occurring. The Sympheos system turns knowledge into action. So the data that's collected in the system, which is most importantly, the positive and negative result, but also the geolocation, duration of symptoms, and what symptoms are present, and also then gender and age. That knowledge is then converted to insights through the heat map of the outbreak, which identifies hotspots and is able to track the virus path, also able to measure key quality metrics and provide information for public health measures and interventions, and also gather critical epidata. This will lead us to actions to enable MOH and other stakeholders to get ahead of the virus, and also deploy surge resources where needed, and have other specific activities that are going to be related to halting the spread of the pandemic. So I will now speak about active infections and antigen testing. So evidence strongly indicates that molecular detection above a CT value of 33 is from defective or non-infectious virus. So studies from the CDC have shown that from when samples have a CT value over 33, infectious cultures could not be obtained. Scholar et al. Also demonstrated the non-viability of virus from samples from a CT value of over 33. And in another study by Bullard et al., no growth was obtained from samples even at a CT value of over 24. So the inferences from this data is that RNA can be readily be detected from defective or inactivated or partial non-infectious virus or viral particles at high CT values. And this explains why the PCR and other amplification tests remain positive weeks and possibly even months after a person has gone through the infectious phase of the viral illness. So whilst molecular is an extremely useful tool and is deemed to be the gold standard, we need to understand what is actually being detected when we have samples with a very high CT value. So what the take home of this is that the antigen test is only most effective or most sensitive and specific when it's detecting samples that have got a CT value of less than or equal to 33. And that is important because the antigen test is then detecting active and replicating virus, which is important, which is what we are actually looking for when we are trying to halt the spread of the virus. The molecular tests could tend to be very sensitive and able to detect defective or inactive viral particles, and that will be indicated by the result having a very high CT value. Time is also a key factor when considering active infections. So viral shedding appears to peak at around the time of the onset of symptoms, but as I stated, real-time PCR can remain positive for weeks. But beyond 9 to 10 days post the onset of symptoms, positive cultures are difficult to develop. And when culture remains positive beyond 9 days, it is in some Lavezo et al. have stated that this would be associated with high viral loads. So the inferences are that the infectious time frame for patients seems to be highest within 0 to 7 days post onset of symptoms, which corresponds to the most effective time of the Panbio antigen test. PCR positivity after this seems tied to very low viral loads and or defective or non-infectious virus. And infectiousness beyond the time frame of 0 to 7 days is associated with high viral loads, but is infectiousness beyond that time frame, which is not related to high CT values, is associated with subjects that have got high viral loads. So in summary, Panbio COVID-19 antigen tests for virus in the infectious phase, which is when it matters the most. The findings are that Panbio COVID-19 antigen sensitivity was 94.1% as per the CE mark for samples with a CT value of less than or equal to 33%, which is when the infectious virus is most likely to be present. Panbio COVID-19 antigen targets the 0 to 7 day time period post the onset of symptoms or the suspicion of infection. And this early phase is what matters in terms of contagion and transmission. Early detection not only yields faster treatment decisions, but also helps to break the transmission cycle. And this test is cost effective and it is deployable at the point of care, which can enable effective mass screening to halt the pandemic. So I just want to look at two suggested protocols that we have been providing to countries who are interested in conducting in-country evaluations of this test prior to registration or prior to in-country adoption. So these are suggested protocols. Obviously, the evaluation of a product in any country is the sole responsibility of the MOH or any other competent organization that has been tasked with this. So these are suggestions from the legal manufacturer as to how this test could be evaluated rapidly and be able to provide quality results for an in-country evaluation. So the first protocol is what we call the Prospective or the fresh nasopharyngeal specimen. So the primary objective of this document is to provide the minimal technical requirements to generate a protocol in order to evaluate the clinical sensitivity and specificity of the Panbio COVID-19 antigen rapid test using a freshly collected nasopharyngeal specimen based on results obtained from the reference molecular test as reported in the IFU of the product. The study population would be clinically suspect as well as meaning the symptomatic people with COVID-19 who have got a stated less than 7 days from the onset of symptoms. So for the in-country evaluation, you will need to have symptomatic people for this evaluation. So the sample size, we are recommending a minimum of 30 symptomatic subjects who test positive for COVID-19 and 140 subjects who test negative for COVID-19 by the reference method used by the reference laboratories or by the standard of care for the country. So that the patients or the subjects will have to have 2 nasal pharyngeal swabs conducted on them simultaneously or within the same time period. So one swab will be collected and used to conduct the Panbio antigen test at the point of care, and the second swab will be transported to the reference laboratory and tested under the reference methodology. So the first swab will be placed into VTM immediately following collection and sent to the reference laboratory following the guidelines that exist. And the second swab needs to be tested immediately on collection for using the Panbio COVID-19 antigen following the instructions for use. So so the swab will be placed into the extraction buffer as we had stated. The swab has to be placed and tested within 2 hours from the onset of the sample. So you cannot conduct a Panbio antigen test if the swab has been placed into the buffer solution more than 2 hours after the collection of the swab. Results from the testing with the reference molecular method will then be compared with the Panbio COVID-19 antigen rapid test results, and customers need to follow the instructions without any deviation from the IFU. We have a second protocol that has been developed based on requests from customers in the field. This relates to samples or archives of frozen VTM nasopharyngeal specimens that have been collected in different countries, and countries would now like to use those samples, especially countries that have very few active cases of COVID-19 at the moment. They have considered the use of these frozen VTM nasopharyngeal specimens in order to conduct an in-country evaluation of the Panbio antigen test. So there are some limitations, or many limitations, to trying to use a frozen VTM nasopharyngeal specimen, but we have tried to provide some guidelines around that. Our recommendation would be to use the fresh samples, because that would give you a more accurate and correlation to the PCR. There are some challenges with the frozen VTM protocol, but just to give you the guidelines. So we have been requested to recommend viral transport medium that could be used. Obviously, there has been a global shortage of viral transfer medium, and many countries and many laboratories have been forced to make their own home brewed VTM, and also use many other VTMs that they can get on the market. So these three are not by no ways inclusive or exclusive. This is what we have tested on, but surely there would be many other VTMs that could be used. But as per the instructions for use, when you use a VTM sample, you introduce an additional dilution effect. And so you would have to follow the instructions and make sure that you dilute you calculate what the dilution effect has been, and also to know that the dilution effect adds what would be equivalent to approximately 4 additional cycles to the real-time PCR. So what we are proposing is that if you're going to use the frozen VTM samples to conduct an in-country evaluation, you need to use only samples that have a cutoff CT value of 29, as opposed to a cutoff CT value of 33 if you were using fresh samples. Also to mention that this frozen VTM guidance is only provided for the in-country evaluation of the test, but this VTM is not, frozen samples are not an acceptable specimen to be used for the ongoing or routine testing with Panbio antigen test. So you need to pre-select frozen de-identified retrospective VTM specimens. The conditions are, it should have been stored at -80 degrees and not more than 3 months. It should not have undergone more than 3 freeze-thaw cycles, and the samples needed to have been collected from symptomatic patients. So this protocol then assumes some conditions which would not necessarily have been in place, and presumes some kind of foresight that we might not have had. For example, many of the samples that are contained in the country archives, there's no indication as to whether these were collected from symptomatic patients or from asymptomatic patients. And also there's no data in most countries about the date of onset of the symptoms versus the date of the collection of the sample that is now coming in the form of a frozen VTM nasopharyngeal specimen. And that was not information that might have been collected at the time of collecting these nasopharyngeal swabs. So for this protocol, we are recommending a sample size of a minimum of 50 positive samples and a minimum of 50 negative samples that are of people with COVID-19 based on results obtained from a reference molecular method. And the VTM should have been frozen at minus 80 degrees for not more than 3 months. So with the micropipette, you fill 150 microliters of the extraction buffer into the sample tube, and then with the micropipette, you dispense 150 microliters of the thawed VTM solution into the sample tube and fill it with the to the tube that is already filled with the extraction buffer. So that gives you a dilution ratio of 1:1. You mix and ensure that is thoroughly mixed, and then you dispense 5 drops of the mixed solution onto the device. You read the results within 15 to 20 minutes as per the Panbio COVID-19 antigen rapid test device IFU. So the handling of samples and extraction buffer requires special lab precautions and safety procedures. So you need to follow your own lab and local guidelines and procedures. So this slide is for illustration purposes only, and it's adapted from guidelines published by FIND, Africa CDC, and IDSA, and it is intended for informational use only. Customers and Ministry of Health and other competent authorities are solely responsible for designing and implementing testing strategies and for making any decisions based on test results. So if we look at this suggested pathway, if you start on the left with a suspected subject, a person who is suspected of having COVID-19, they are symptomatic and they're less than 7 days post the onset of symptoms, or maybe they have got a defined exposure, so they're within a 7-day period. It is appropriate for the COVID-19 antigen test to be conducted on this subject. If the COVID-19 antigen test is positive, that person is positive, and there's no requirement of a confirmatory test for somebody who tests COVID-19 antigen positive. But then the next step would be to do contact tracing, and 2 groups of contacts that could be identified would be contacts who are less than 7 days post a defined exposure, or who are also symptomatic themselves and also symptomatic with less than 7 days. Those, it would be appropriate there to conduct an antigen test on those contacts, but also a molecular test if available. And then you have another group of contacts who are more than 14 days post the exposure, and possibly an antibody test could be appropriate in those people to demonstrate past exposure. If we go back to the subject, the index case. So if the COVID-19 rapid test is negative, then the negative test must be combined with the clinical observations, the patient history, and epidemiological information. So a negative test does not preclude the presence of COVID-19 illness. It would be appropriate to consider molecular testing if the clinical observation and the signs and symptoms are suggestive. But this is, yes, so it would be appropriate if you still suspect that the person is possibly having COVID-19 illness, and they test negative on the antigen test, it would be appropriate to consider a molecular test. But if they remain negative and they're now 14 days post the onset of symptoms, then an antibody test might be considered. Of course, an antibody test will be important for the general use when we're looking at surveillance testing. Thank you very much. That's the end of my presentation.
Thank you very much, Kuku. Wow, wonderful presentation. And thank you everyone for all the questions coming through, lots and lots of questions indeed. Important subjects from verification, sample types, safety, cross-reactivity, interesting indeed. And that's why at ASLM right now, we are also glad to have this session that will also guide us in the document that we are developing together with our partners. ASLM and partners are developing a document to guide on antigen rapid testing, and we hope that this could be available as soon as possible, hopefully in November or thereabout. So let's take the questions. I know there are quite a lot of questions, so we'll try to take them hopefully by theme. And I think there are quite a lot of questions with regards to issues of verification. And thanks also to Evans and Jose for answering some of the questions. When it comes to verification and validation, I think there was a question that caught my eye. Why recommend validation? Why not give the guidance and have countries move on?
I think so countries have indicated that in order for them to move on, they need to validate the product in country, and that is based on in country, each country's regulations for registration or for provision of tests onto the market. Some countries have said that based on the WHO EUL, they would like to move along, but we have had a lot of recommendations, a lot of requests from countries for us to provide very specific guidance on how they're going to conduct these verifications or validations, and that is why we have provided these guidelines. But they're just recommendations. They're not. We're not saying that you have to use this specific guidelines, and we just providing them as a baseline for countries to develop their own validation protocols and then move forward with making decisions as to how they want to conduct testing in antigen testing in their country. I hope that I'm answering the question.
Thank you, Coco. Yes, I think you are answering indeed, and it cements what we have been discussing in the previous sessions. I think the key issue is here not to encourage repeat validations, but maybe rather at a minimum that those simple verifications is just part of good laboratory practice, but we need the technologies to be adopted as soon as possible and serve their purpose. So I think we are also happy that there are also protocols out there. Hopefully we can be able to share with the rest of the community together with the materials for this. Moving on, another important question before we really get into the technical issues, COVID-19 and the issues of infectiousness. There were quite a number of questions around safety. I'll just pick one of them, and many you can address maybe related issues. Aileen says, for PPE, is an N95 mask required? I think this is a representative question for all safety-related issues, given that this RDT is going to be moving beyond the laboratory as it is with the molecular test.
So I think that generating a nasopharyngeal swab does generate the possibility of droplet infection, and so a person who is conducting a nasopharyngeal swab has to respect all the biohazard or all the protective measures that they possibly can, and this is country specific. So we don't have, as Abbott, we don't have any information as to whether the N95 should or must be used when collecting a nasopharyngeal swab. But then again, nasopharyngeal swabs have been the only method of collecting samples up until the availability of other tests. So as the country has already defined what would be the minimum PPE that would be required to to conduct a nasopharyngeal swab, that is what should pertain. I mean, we must also be aware that N95 masks are somewhat in short supply, and also there is the issue of reusing an N95 masks and whether they remain effective when they've been used for maybe a week after a person has used an N95 mask continuously for a number of days or a week. Is that mask still very effective? But that is not that we don't have the expertise on the issue of the N95 mask or anything related to PPE that is involved in conducting a nasopharyngeal swab. Thank you.
Thank you again, Kuku. I'm tempted to quickly also go into the lots of questions around how to technically run the test. But maybe before we also reach there, also interesting questions coming through as well. The use cases. Where do we use this? I'll use this from George LMG. Is the COVID-19 diagnostic community considering a combination of diagnostic algorithm to include the most sensitive tests as the first and most specific, and the most specific one as the second, particularly lessons from HIV? Possibly this could help us address issues around positive results being seen with antigen test. This is a lesson that we have learned from HIV. And I think there are quite also a number of questions that were talking to the issues of sensitivities and specificities, where there is a certain cutoff of 80 that has been there. Maybe let me leave it there for you to comment and colleagues if they want to, Evans and Jose.
Yes, I would say that in terms of the use cases, some of the possible use cases would be around triaging of people that present for testing, and also contact tracing. So these would be some of the use cases, but it's important for there to be discussion and consensus among a whole broad spectrum of stakeholders, not just the manufacturer. So the manufacturer we have provided the test and we have provided the conditions for the test to be used, but in terms of how the test should be used with regard to specific challenges that we're facing around opening up the economy, testing in workplaces, schools, and airports, this requires a holistic or multidisciplinary approach. And no one stakeholder can just state that the test can be or cannot be used in a specific setting. So there are possibilities of using this test. For example, we are aware that the South African government has issued notice to say that antigen testing will be provided at land borders for people that were not able to obtain a molecular test at the time of their travel. So in some countries where molecular testing is not so readily available for somebody that's not having a clinical issue but wants to travel, there is a possibility that antigen tests would be provided would be available at cost to the customer, to the traveler at the border post. So that is something that the government itself has decided, and I believe that is the appropriate way to go, where communities such as ASLM, such as Africa CDC, and other competent authorities would be able to engage stakeholders and discuss what would be the most specific use cases for these tests. And also bearing in mind that these use cases will evolve as our increased knowledge of the pandemic, increases. Thank you.
Thank you, Kuku. Indeed, diagnostic algorithms, clinical algorithms, really key as we move forward. You mentioned the issue of borders coming through, quite a number of questions in the chat. Picking one example from Sabine, who is asking also whether there is, okay, this one is not really on that. I'll touch that one next. I think there was a requirement whether a positive antigen test should be confirmed with a molecular test and the implications possibly when people are traveling?
So our position is that a positive Panbio COVID-19 antigen test does not require a confirmation with a molecular test. So if depends on the timing of when the test is done with relation to the traveler, whether it's at the time of departure or whether it's at the time of the entry. But as I said, some countries are saying that as you enter the country, we would like to confirm that you're not in the infectious stage of the COVID-19 illness.
Thank you once again, Kuku. I think moving forward, let me just also touch a bit on the test itself. I think there are quite a number of questions that came through. People were asking about the time to result. I remember a question around, if you read it after 20 minutes and it's positive, what does it mean? And then there's also Gibson, who says, is the color intensity on the test line proportional to the amount of the nucleocapsid antigen material in the sample? Maybe let me touch those two as we move on.
So the test is read at 15 minutes and the maximum read time is 20 minutes. It's not possible to read the test after 20 minutes. So if 20 minutes have lapsed, you need to repeat the test. And then with regard to the intensity of the line, no, this is a qualitative test, so you cannot infer anything additional from the intensity of the line, and any form of shading in the test area should be deemed to be a positive test. So we don't make any claims around the intensity of the shading and
All right. I don't know whether I'm the one who lost connection a little bit. Hopefully you can hear me. Can you hear me?
Yes, I can hear you now, but there was maybe a millisecond of silence. So I hope you hear the end of what I was saying.
Yeah, I'd lost that bit.
Okay.
Yeah.
So I'm saying that it's a qualitative test, so you cannot infer anything from the intensity of the line, and any shading in the line in the test area is a positive test.
All right, thank you. There was also a line of questioning around relevance of CT values. What this means, according to John Temple, he says, is the protocol to test someone with antigen test when their CT value is high to see whether they have an active infection that is still there.
The protocol is to test somebody with a lower CT value. So the CT value, because the molecular test is very sensitive and is able to amplify any viral material that is any genetic material that it's able to obtain. So it will be positive for many a wide spectrum of samples. But what we are saying is that the antigen test is only able to detect people that are within day 0 to day 7 post the onset of the infection. So in order to create a subset of people that would be both PCR positive or molecular test positive and antigen test positive or negative in the reverse, you need to exclude people who have got the nature of the material that is being amplified would suggest that it's not infectious material and that it might be viral particles that are being shed. So that is where the CT value comes in, that when you have your batch of samples, you need to exclude people that have got a higher CT value, because those are not what this test is measuring. This test is measuring people that have replicating virus and that are infectious. And in order to do that, you have to make a cut of CT value from all the people that would test a real-time PCR positive.
Thank you once again. Then another important question that probably we should touch before we end this session would be sample types. Just to clarify that there was an issue of nasopharyngeal swabs? Any other sample type?
Currently, the test is only available with nasopharyngeal swab. So obviously, it would be ideal to have other sample types, because nasopharyngeal swab is both quite invasive and also uncomfortable, and also maybe is more likely to generate some kind of particles or some kind of droplets for the operator. Nasopharyngeal swab also requires a person that knows the anatomy of the nasopharyngeal passage in order to conduct that test. So there are some limitations in using a nasopharyngeal swab, but at present, this is the sample type that we have registered this test on. And as time goes on, we will see whether we are able to register any additional sample types.
Thank you once again, Kuku. Moving forward, excuse me. I think maybe before we, still around the sample types, there was also quite a number of questions around the transport media. And you also mentioned the possibilities of us making our own homegrown transport media. Maybe another comment on that.
No, I wasn't saying that you can make it. I'm saying that you have made it. Like countries have been forced to make their own transport medium. So in the guidance that we have provided, we've just mentioned, because there was a request from customers saying that we should recommend the type of transport media that the frozen VTM samples should have been stored in historically. But you know, it was collected at some time in the past, and which one would be the best transport media that you could use in order to conduct this evaluation, in-country evaluation or validation at this stage. And we are saying that we don't have information on a whole broad spectrum of VTMs, but the ones that we know about are those ones that were stated in the guidance. But bearing in mind and giving a heavy proviso that it's unlikely that many people would have had those specific VTM samples, and we're not precluding the use of other VTM samples, because we haven't done an exercise to see what other VTM samples used in different countries and what do they contain, and are they effective. But just again, I will say that the second protocol for validation, where you use a frozen VTM sample, is a more difficult protocol to carry out, because of the quality of the nasopharyngeal swab stored and frozen in VTM. It may not be a very stable specimen. Thank you.
Thank you again for that clarification. There is also a key comment in the chat from WHO, and Anita is also online. And I just want to make sure that we don't want to misrepresent facts. And she has mentioned that WHO is not recommending use of antigen RDT, formally recommending use of antigen RDT for airport and border crossings.
Yes.
And she has also applied, given us a whole reference in there.
Yes. Yes. I'm not saying that. I spoke about the South African government issuing a notice to say that to enter South Africa, there is a possibility that you could have an antigen test at the border post. And this was, I think, targeting specifically the land border posts with Eswatini and with Lesotho. But I'm not saying that any other organization has recommended the use of antigen in airport screening.
Thank you. Thank you. However, this is a very relevant discussion, and it keeps on going in the chat. For example, here there's a chat, I think Doris and then I think George talking about the situations in countries, and here is an example of Cameroon. What are the elements that we are looking out for, TAT, and what will be important is really to evaluate the impact of all these approaches as we move on. So I guess as we are moving on, we are collecting information, we are collecting data that can be analyzed. This takes us to a similar to a question which is also applicable and similar to what we focused on in the previous session, digital solutions in the COVID-19 era. And we are glad that you have provided the example of the Sympheos. And I could pick quite a number of questions, and let me start with the one that asks for whether this is free. How do countries get the Sympheos?
So I think that my colleague Jose is online, and I would like to hand over to him to answer quickly about the Sympheos system.
The Sympheos system comes for free with the COVID-19 Panbio antigen test.
Come again, Jose.
Sorry, can you hear me, Blair?
For free.
It comes for free with the COVID-19 antigen, Panbio antigen test.
Okay, thank you. Thank you very much for clarifying that as well. I would want us to respect the time that we have allocated, and it's just a minute after the hour. Just to reiterate that there are quite a lot of questions here, and we are glad that many of them have been responded also in the chat. So what we will do is to compile them as usual and share. Just want to also reiterate that we at ASLM and our partners are also trying to make sure that this package, the training package for the antigen RDT, is going to be as available and as accessible as soon as possible. And many of these key issues that have been raised, hopefully, are going to be addressed in that package. So watch out for that soon. Coco, I just want to give you 30 seconds to just give us just some parting remarks.
No, I would just like to thank you, Anafi, and also just to commend ASLM for providing this most amazing platform for us to be able to exchange important information around diagnostics, not just in Africa, but globally around, there's a need for guidance, there's a need for consensus, there's a need for discussion. And I think the fact that there are so many questions in the chat box speaks to the need for that this series has been exceptionally successful, and that there is a need for ongoing discussion and bringing everybody together on one platform. So I would like to thank you very much, and thank everybody who has participated in this discussion. Thank you all, and please do reach out to us if there are any specific questions that you have. Thank you very much.
Thank you, Kuku, and on behalf of ASLM, I would like to thank you and your team at Abbott for coming through and providing us with this important information as we move forward. Also want to thank the participants for coming through, and to borrow Kuku's words, this series, this platform has been for guidance, for consensus, for discussion, and many more. So I think we will continue to make sure that we try to offer this platform until we win the fight against the pandemic. Talking about using of this platform again, we are looking forward to a session this Friday where we are also going to zone into the details like we did for another rapid diagnostic test in the name standard Q from SD Biosensor. So please watch out and keep checking your mails. We should be sending the invite soon. Right now on your screen would be the code for downloading the certificates should you require any documentary evidence of having participated in this. And as usual, please go to the ASLM Academy, sign in, sign up if you haven't yet, and you should be able to download and be able to access some of the other resources that are coming there. Till we meet again, I would say good morning, good afternoon, and good evening. Bye-bye.
Thank you. Bye-bye.
Thank you.